Great. Thanks so much. It's going to be an interesting challenge to present an overview of BPD for a mixed audience and know that I'm going to be followed by, I'll talk a little bit about meds, but I'm going to be followed by the world expert at medications and BPD, Ken Silk. I'm going to talk a little bit about DBT, but Blaise Aguirre runs a world-renowned DBT program at McLean. I'll talk a little bit about families, but Perry is like the family person. So we'll see. I will do my best to try to tie this together. And what my goal here is to at least give us all the same language or some similar ideas that can undergird the more in-depth presentations that we'll have during the rest of the morning and afternoon. So I'll talk a little bit about the diagnosis, the epidemiology, and the biology. But let's start with some myths. First, it's a myth that it's unwise to share the diagnosis. I'll show you some data on this. Second, it's a myth that you cannot make the diagnosis in an acute setting. So I work currently on an inpatient unit where we accurately diagnose BPD and should. And I'll show you some data about that as well. Third, it's actually a myth that you can treat comorbid axis 1, meaning depression, anxiety, the common things that bring people to psychiatric care without treating BPD. And I'll show you that as well, that many of you have been a part of families or seen professionally people with depression. But what is this depression and what's going on? And when we can figure out, oh, this is BPD, it would really change the treatment and change the outcome, actually. It's a myth that borderline patients try to defeat their therapists, although I do have one patient in the audience who I had to question. It is a myth that patients with borderline don't improve. I'll show you that data. And it's actually also a myth that you have to know dialectical behavioral therapy to treat borderline. And I'll show you actually more of what's in common among the 6 empirically validated treatments than what separates them. So let's talk about the diagnosis. What is this entity called? And I've grouped the criteria in 4 phenotypes, 4 areas. And they're together for a reason, and they're organized this way for a reason. The first is interpersonal. And borderline is ultimately an interpersonal disorder. The emotion dysregulation does not occur in a vacuum. It occurs in the context of an interpersonal stress of some sort. So it can evoke abandonment fears, unstable relationships, changing from ideal to devalued, and chronic feelings of emptiness. Those are the 3 official criteria, but those are interpersonal. The second group of criteria, now there's debate. Marshall Linehan will say this is the most important. John Gunderson would say the interpersonal is most important. I'm not trying to referee a debate, but I think there is something that the emotions are clearly dysregulated, and that is what causes problems, coming in the context of some sort of interpersonal problem rather than just out of the blue on an island. And I think that's an important concept that we'll talk a little bit more about. So affective instability. I'll show you some data in a minute that a lot of people are diagnosed bipolar because the affect seems so unstable. Although it's rare in borderline to have elated mood where people feel just on top of the world for days at a time. It's more common to have several hour periods of depression, that kind of thing, or even several hour periods of being up, but that's not the same as bipolar disorder. Inappropriate, intense anger. Third, behavioral discontrol. This is what usually brings people to attention. Recurrent suicidality, threats, self-harm, impulsivity, sex, driving, drinking, binging. A disturbed sense of self is the 4th, an unstable or distorted self-image. And then under periods of extreme stress, depersonalization or paranoia, these quasi-psychotic symptoms that can emerge that actually don't, unlike schizophrenia, they don't persist outside the period of the interpersonal distress. So this is Dr. Gunderson's work, but I think useful that when I work with residents, which I do a lot now, they will say to me, well, that patient didn't feel borderline to me, by which I think they mean she wasn't angry. And I think understanding the context of these interpersonal issues is important. So if the patient feels cared about, they can often feel more depressed or waif-like or held. When patients feel threatened, they can appear angry, self-injuring. And ultimately, when patients feel alone, this is when the desperation, impulsivity, suicide attempts come. It's a clinical pearl that borderline patients are at risk for suicide when they conclude that they can't be loved. And I think that speaks to this changing interpersonal context of the disorder. So, as I teach residents, taking history, are the symptoms triggered interpersonally? Was this a breakup that prompted this depression? Is the depression treatment resistant? Meaning we've tried a lot of different things.
Slowly. I mean, I can't even hear what you're saying, and I certainly can't copy down because you're going so fast. Is it in the book?
The slides are in the book, absolutely, yeah. And I will certainly go more slowly. Thank you for raising the point. Is the depression treatment resistant? Meaning, is this, we've had lots of med trials for this. Third, does the patient self-harm? And I'll go through in a minute. What's the function of the self-harm? What's it doing for the patient? And are the relationships unstable? So when we give the diagnosis, this is a small study unpublished at McLean, which I liked. It turns out that people, when you tell them they have borderline, they don't feel any more or less shame. They don't see themselves as any more or less likable. But they do feel more hopeful and overall have a better sense of their own future. And I think that there's something really important about naming what's going on. But, oh, okay, well, if that's what it is, that's what it is. It's important to have a name for it and important to be able to make sense of the experience. So the disorder occurs, it's common. In mental health samples on my inpatient unit, about 20% of clinical samples have BPD. The general population estimates are tough. I usually quote 2 to 3%. The 5.9% number I think is high, although it comes from the largest, most well-done of the studies of 40,000 people with door-to-door interviews in communities, so interpret as you will. In clinical samples, it's about 75% female, although in the community samples, it's more equal with men and women. There is some thought that I think may be accurate that men are often pushed into the criminal justice system more quickly and may be treated for substance use disorders more primarily than women, and so that could affect the gender bias here. I don't think we have a clear understanding of that yet. So this is data from Brown, which is certainly a world-class center, but I think is typical of most places. In the outpatient sample that they looked at, they had 61 patients who met criteria for borderline. And they looked and said, who was given the diagnosis? It turns out 2 of those 61 were told, you have BPD. And for those of you who have been around the mental health care system and have seen lots of providers, my guess is that's very typical of your experience, that it's hard actually to get this diagnosis made. And I think we can speculate on the reasons professionals feel anxious, uncomfortable. There's certainly a lot of stigma, a lot of kind of counterphobic response that I don't want to upset you, I'm scared it really is not very helpful on the part of professionals. Also, this issue of bipolarity, 40%, there are patients with BPD who do have bipolar disorder also, but 40% of patients who have borderline but do not have bipolar have been previously told you have bipolar disorder. So that is a very common misdiagnosis that we see, and I imagine most of you have had that experience. I actually think, in my experience at good places like McLean and Mayo, it may actually be slightly higher than 40%, to be totally honest. So, comorbid, UCLA also, yes, okay. We have confirmation that this is true around the country and is not good at any of our fancy places. Comorbid depression does not affect the accuracy of borderline assessments. And this was big news. This was in the American Journal of Psychiatry last January, a study that just asked the question, if someone's depressed, can you accurately diagnose borderline? Or, as had been taught to me when I was coming through residency, you really need to wait until the depression lifts before you can see what's there. Turns out that the diagnosis of borderline is just as accurate when someone is in the midst of a major depressive episode, which is good news. So this is certainly as genetic as every other psychiatric illness. When we looked, I say we, I didn't do this, I'm just reporting somebody else's data. Among 92 identical and 129 fraternal twin sets, now this is a complicated statement, and I have to say it exactly as it's written. Genes accounted for 69% of the variance in diagnostic concordance. That sounds impressive. What that means, if you've got two twins, how often do they have the same diagnosis? So if you've got two twins, how often are they both borderline, or how often are they not borderline? Of the difference, when you've got one borderline and one not, you can figure out that about 69% of that difference is accounted for by genes. So we say it's a very heritable disorder. That's how you interpret these twin studies. I could burden it with more detail, but at this point I will just leave it at it's a very heritable disorder. This is coming from, as is true for most of our major mental illnesses. And across the 9 family studies that have been done, about 12.6% of first-degree relatives of people with borderline also had borderline themselves, which is 4 times higher than the non-BPD probands. Meaning, if you've got a relative with BPD, you're certainly a lot more likely to have it yourself. Does that make sense? Okay. So its heritability ranks. These are ballpark estimates of how heritable, and the science gets a little tricky to actually do and interpret, but ballpark estimates of how heritable a lot of common psychiatric illnesses are. Borderline ranks right up there in terms of its genetic causation. Does that make sense? All right. This is the last part of the science stuff, but these next 4 slides, I guess, tie together, and I want to explain a basic understanding of how the brain regulates emotions. Okay, so this is not on the slide. I'm just going to tell it to you first. So there's 2 parts of the brain I'm about to talk about. One is the amygdala, and the amygdala is a little walnut size. No, it's smaller than that, almond size nugget in the brain, which, when you're feeling intense emotion, is active. It's a very primitive part of the brain. So it's the part of the brain where if you're scared of snakes, as I am, and you're walking and you see a snake, you get that instant fear response before anything else has even occurred, and you are suddenly intensely fearful and aware of that. Then what happens is the other part of the brain that I'm going to focus on, the cortex, the thinking part of the brain, kicks in and sorts it out and says, okay, I'm in a zoo, the snake is behind glass, I think it's going to be okay. Okay, all right. And this happens for us actually a lot during the course of a day, this interaction between the emotion processing system in the brain and the thinking part of the brain, which helps us sort out what's happening with the emotions. Because the emotions are providing us important data. It's good to be afraid of a snake, but it's not always good to be afraid of a snake. You have to be able to decide when you should be afraid of the snake. Does that make sense? Now, I think you get where I'm about to go with this, because those of you who live with borderline patients or treat them or are them, you know that this doesn't always work so well. So they did a great study where they showed people with BPD faces, these 4 faces, called the ecumene faces, they're standardized. And this woman is expressing 4 different emotions. The first one, you can decide what you think it is. She's neutral. Those of you who saw her as angry, which I actually did the first time I saw these, borderline patients are much more likely to interpret her face as angry. Then happy, sad, and which, by the way, if you interpret neutral faces as angry, I mean, this is a problem in terms of relationships that is going to show up for you. And even in our brief survey of ourselves just now, some of us saw a little anger in her eyes, and others were like, oh no, that's neutral. And you can think for yourself just where you fall on that. Hopefully you've got a good cortex that kicks in and sorts out, okay, she's just a picture on a screen. But, okay. So what happens is that in response to all 4 of those faces, the borderline patients in this study showed more activation of the amygdala. So that's this part right here that's lighting up in the borderline patients compared with the control patients. So even the neutral face got more activation going in the amygdala for all 4 of those phases. And I think in DBT, Marshall Linehan says that borderline patients feel their feelings more deeply than other patients. And I think that's absolutely true. And in some ways, we're looking at the neurobiology of that you've got more activation in response to the same emotional stimulus in borderline patients than you do in others. This is a small study, but it makes a really good metaphor that explains a lot of what I'm going to talk about with treatment. There's debate, I think, actually, in the specific parts of the cortex that what happens in terms of how they work, and there's some different theories that go on. But basically, the neurobiology tends to be something on the order of enhanced emotional arousal with decreased ability to sort things out. This is where it's good actually not to be the world expert at something, because I'm allowed to give a lay, simplified explanation where if I actually researched that and did that study, I would have a lot more precision that I'd be required to tell you about. So I hope I'm not being too loose with the interpretation, but I think it's an accurate one. So let's talk about what happens with borderline patients. This is, the first slide is the concerning slide. Suicide is common, about 10% complete a suicide. 65 to 70% make at least one attempt. Self-injury is common, cutting, burning, bruising, head banging, biting, seen in 75% of patients. Concerning. Why do people self-injure? What are the functions of it? What do they get out of it? This is, I think, a useful and interesting study that just asked that question. This is the percent of the population of borderline patients that were interviewed that agree with this function. So obviously this adds up to well more than 100%. This is how many people agreed with this. To feel pain, to inflict punishment, to reduce anxiety or despair, to feel a greater sense of control, to express anger, to feel something, to seek help from others, to keep bad memories away. And back to my earlier way of thinking about this, all of these have in common, they're an attempt to try to do something to manage an internal state that is difficult. And if we think of self-injury that way, or we think of drinking or driving too fast or using, or we think of the things that I did yesterday when I was distressed at work, and we all have our ways to use behavior to help us re-regulate, and these ways often then cause other problems. The downside is that when you use these other ways, then the problem is gone. So you feel better, but you never got the chance to sort out what was happening emotionally. The moment's passed and you're on to the next thing. So chronically, you end up creating for yourself, unfortunately, this sense of an inability to understand what's happening inside. So darn, you just at the moment, and this is why all the treatments now use that moment of self-injury or anything else as a marker to get curious, like, whoa, 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 red flag. What was happening inside you at that moment, and how do you go back and get better at sorting that out? And if you can sort that out, then actually things will go a lot better, and this is what most of these treatments have in common, is an attempt to do exactly that. So how do people do long term? There are 2 big studies, and I'll show you a couple highlights from both of them. One is the McLean study of adult development. This is a study from McLean Hospital. They took people off the inpatient units who met criteria for borderline. There were 362 patients, and these were people who had been admitted to the hospital, often for some sort of suicidality or severe mood episode, the reason people get admitted to hospitals. So they completed, actually now, 7 2-year follow-up waves, and Dr. Mary Zanarini is the principal investigator on this. Many of you know her and know her work. She's certainly active in the community and has amazing retention. She's managed to keep so many of these patients in. What she published that really shocked people is how common remission was. So within 2 years of the diagnosis, 35%, 34.5%, no longer met 5 out of 9 criteria. This was a shock. And by 10 years, 82%. And I think there was a bias in mental health, because we only see people who keep coming back. So we just assume nobody ever gets better, which makes one hopeless about one's work, by the way. See the problem. But if you look at a population going forward, it turns out that people can get quite a bit better, which fits. You don't see very many people in their 50s that are still self-injuring. So something changes over time, which makes common sense, but until Dr. Zanarini had pointed this out, I think a lot of people really had been under the assumption that this was a lifelong disorder that never got better. And I think this is a very hopeful sign. The other thing she found that was really cool is that once people achieved remission, they very rarely got worse. So once it got better, they rarely went back to meeting the criteria, which now we're talking about something that we don't see anywhere else in psychiatry, because even depression, which is a fairly well-treated disorder, is often recurrent. In fact, if you've had one episode of depression, there's about a 50% chance you'll have a second. 2 episodes, about a 70% chance you'll have a third. If you've had 3 episodes, there's a 90% chance you'll have a fourth and a fifth and a sixth. Depression is a chronic recurring condition. And we're now finding that borderline, actually, if it gets better, stays better, which is a very encouraging aspect of this work. She found, and the other study doesn't quite replicate this, and her later studies are less clear on this, but I think it's useful to think that the symptoms all declined, but not quite equally, that the impulsive group, the behavioral group of symptoms, were the ones that improved first and improved the most, followed by cognitive, interpersonal, and then affective was the least improved, the least quick to improve, which I think in some ways is a bit sad, that those chronic feelings of emptiness, the difficulty with emotions do persist, but people can get quite a bit better at managing them. And I think that's what that data shows. The other big study is a multi-center study. John Gunderson was the principal investigator on this with colleagues at several institutions. And this also completed 10-year follow-up. And on this slide, we have plotted the 2 sets of data that I'm talking about together. So on this blue line was the data I had just told you about how the percent that achieve remission from Dr. Zanarini's work. So everybody got the blue line that I'm pointing to. That's the percent that achieve remission at year 2, year 4, year 6, year 8, year 10. The salmon colored line, or whatever color we shall call that, is the number of criteria out of 9 that the people in the other big study met. So at year 0, the average person met 6.7 of the 9 criteria. By year 1, they only met 4.2% of criteria on average, on down, on down, on down. So now we've got 2 big studies that show essentially the exact same thing. Patients get quite a bit better progressively over time when you follow a population of patients forward. However, at the end of the 10-year data on the collaborative longitudinal personality disorder study, only a third had full-time employment. Concerning. So that the functional impairment caused by this persists. People get off their trajectory. Most of the patients, when I was working at McLean, a lot of the patients I was working with didn't quite finish college because their symptoms got so bad that they didn't graduate, and then were they going to go back, and now they're off that trajectory. They're not accomplishing the tasks that they would do because they're in the midst of being cared for their mental illness. And this translates to long-term functional impairment. Borderline has a markedly negative effect on major depressive disorder, but major depressive disorder had a modest effect on borderline's course. That was also important. So the relationship between symptoms and functioning was also interesting. That as people began to have fewer symptoms, they could function better, which was a hopeful thing. This slide used to have an arrow pointing both directions, that as they function better, they had fewer symptoms, but it didn't quite reach the level of statistical significance in the secondary analysis, so I can't actually say that, but I think it's true. As people function better, their symptoms improve. As people's symptoms improve, they function better. And I think a lot of the treatment programs now are really putting an emphasis on what are you doing occupationally, what are you doing in life outside of just learning about your emotions. Actually, I think McLean really leads the way on that. I was just very impressed with the emphasis on what's going on in life outside of treatment and how do you build that as a necessary part for treatment. So, one big study from this year, I mentioned that large sample of door-to-door interviews, the National Epidemiologic Survey on Alcoholism and Related Conditions. This was a government-funded survey. what they looked at in this was how often depression persists, how often it sticks around, and why. And so they found the people, basically 1996 people, 1,996 people, who had depression that were re-interviewed at 3 years. And in that group, 15% had persistence of their depression during that 3 years, and 7.3% had remission of their depression, but then it came back. So they were interested in this population. By the way, it's kind of encouraging. If you add those numbers together, they're 22%. That means that 78% actually had improvement in their depression. It's a hopeful sign in terms of people getting better. At any rate, the people whose depression stuck around, when they controlled for all of the Axis 1 and Axis 2 disorders, age of onset, number of prior episodes, family history, treatment, duration of illness, anything they could think of to control for. Borderline was the most robust predictor of persistence of the depression. So the people that stayed depressed borderline was the best predictor of who would stay depressed. In fact, 57, this is a quote from their article, and I have to read it because it's precisely written, 57% of cases would not have persisted in the follow-up period in the absence of borderline. So that's a big deal in terms of our field trying to treat this persistent depression. They often get into tertiary depression centers. A lot of these patients are borderline, and we're missing the borderline collectively. So I'm summarizing this portion of the talk. Most patients with borderline achieve remission. Hopeful. Impulsive symptoms get better faster than the affective symptoms. Borderline negatively impacts the course of major depressive disorder, rendering it often treatment resistant. Work and social functional impairment persists even after symptomatic remission. But improving functioning or symptoms predicts improvement in the other one. Helping people function better helps them have fewer symptoms. Helping people have fewer symptoms helps them function better. Okay. All right. You exhausted yet? All right. Yeah, you are. Okay. It's only 9:13. We've got the whole day ahead of us. So please, go ahead. You know, actually, it's a great question. The McLean study of adult development, 70% were, it's a heavily treated sample, 70% were in treatment for much or even all of that period. A little bit less with the CLIP study. So yes, these are people often in treatment, but it's a naturalistic follow-up. It's just saying who of these patients who were on an inpatient unit, what happened to them. So it's not studying the effect of treatment. In fact, we know treatment helps, and I would highly recommend treatment, but we actually don't know. And I think there's probably enough in that data to suggest that people will also get better without treatment, which is a very comforting aspect of this. And we'll talk about the family stuff at the end. My experience working with families, I led a couple of family groups, multiple family groups, and taught a family connections course myself. And we had a number of parents of kids who were in no treatment at all, but as the parents learned to regulate their own emotions better, manage their interactions better, kids actually got better also. I think there's a lot of ways to help people, even if they're not themselves in treatment, by just changing the family environment, for example. So, and I think the data bear that out, but I don't have good numbers on it yet. Principles of treatment. Okay, so how does treatment work? So to start, there's a bunch of levels of care. Obviously, the inpatient unit, residential programs, halfway house, intensive outpatient programs, and outpatient. And different things can happen at different levels. I think people have since I now work on I've worked recently in all of these except for the halfway house in fairly intensive ways with borderline patients. People have an unrealistic expectation that hospitalization is going to fix all the problems. It's about acute stabilization, helps people get ready to treat. What you really want is for people to be in an outpatient treatment program because it keeps them most connected to life. If they can't manage that, then they need more intensive outpatient or residential program to help them. But that's the general principle of what happens at levels of care. There are now 6 empirically validated treatments, meaning they've been studied compared to treatment as usual, and they do better at helping borderline patients get better on all sorts of outcomes. The most well-studied, oh, that slide didn't do well. That's too bad. Well, this slide should say, I don't know, is it correct in your handout? Yeah. Oh, good. So on the left side of your slide, you have cognitive behavioral interventions, and on the right side, more psychodynamic. And I've grouped the empirically validated treatments across that spectrum broadly. This point is probably more intellectual for professionals, but it turns out that there's a whole range of approaches, and in some ways they all work reasonably well. DBT, dialectical behavioral therapy, is the one you've all heard the most about because it has the highest number of research studies. It's effective for treatment of suicidal behaviors and substance abuse. It's a very available package for training. So I work on an inpatient unit now. A lot of the nurses know the DBT skills. They can help patients learn some skills in the course of the inpatient hospitalization, even though they're not doing a DBT treatment, but it's an available package. It's implemented in a broad number of settings. And what is it? And again, this is where I have the expert, he runs this DBT program, sitting in the front row, and I'm going to try to give an overview of this, but let me just try. He'll correct me. The dialectics is this idea that we can split our thinking into all good or all bad, black and white, and usually it's some of both. And we can all get a little non-dialectical ourselves when we feel really strongly that something has to be that way. Okay, so that helps. It's hard to, when you're feeling emotionally distressed, sort out your own thinking unless you feel like you can bring that down. And the fastest way to bring it down is validation. Acknowledging the legitimacy of somebody's experience, finding the kernel of what is valid in the midst of the experience, helps people decrease their emotional reactivity, clarify their own understanding, which I think I implied earlier is really the active ingredients of this stuff. You're trying to help people think about what's happening. So being able to say to them, oh, you know, I can see why you're upset with your mother. That would really hurt. Rather than getting into a debate of whether or not mom is actually the world's largest annoyer. That won't help. I will end up saying, no, your mom's really nice, I've met her. And no, you don't understand. And this will go on. Many of you have had these conversations. By validating and saying, you know, I can see your point. That must have been tough. Then we're into a more collaborative kind of stance, and the emotions can come back down. Make sense?
Brian, I can see you're doing a really wonderful job.
Dr. Thank you. Thank you. That's a compliment is not always validating. Because my experience was I was feeling a little anxious, and if you had said, oh, Brian, I think you're feeling, I could see why you'd be feeling anxious with me in the front row, then that would have been more validating. But I really don't. I'm teasing for teaching purposes. He's wonderful. Acceptance is like, okay, it is what it is. Let's deal with life as it is, rather than trying to imagine some fantasy that is not actually what's happening. And then using behavioral principles of shaping and reinforcement. So skills, and I'm not going to go into too much detail on this, but basic mindfulness skills, the idea that we could be in this moment. And as you're sitting there, just trying to think, how do you be on November 4th? November 4th, at 9:20 in the morning, here at the Carter Center, present in this room, versus ahead tonight to what you're going to do or what happened yesterday or wherever else your mind may be. But how do you actually have the experience you're having right now and notice that? And I told you earlier that a lot of patients with borderline, especially in the setting of emotional distress, have trouble noticing their own experience. That's why this is a core skill that can really be helpful. Plus, it just makes your life better for all of us. Regulation of attention, putting your attention on different places. It diminishes reactivity, impulsivity, dissociation, rumination. The other skills are these: distress tolerance, learning how to skillfully manage a crisis. Cutting works. Cutting causes all kinds of negative long-term problems. What other skills could also help? By the way, they don't work as well as cutting. So I never get into a debate with patients about it. Cutting works better. But cutting causes long-term problems. And if you try the other skills, they don't cause the long-term problems. In fact, they could be very helpful. So that's the approach. Acceptance strategies, accepting, okay, well, this is actually what it is. Fighting against reality is not helping me right now. Emotion regulation, interpersonal effectiveness. We could go into these, but I'm just giving the overview. The other thing that DBT does well, and I think has really taught a lot of us who work with borderline patients, is the expectation of generalization to life outside of a therapy session. So with the use of a diary card where people are expected to write, okay, when did I have the urge to cut myself this week? They're bringing that mindset they get in therapy into life outside of therapy, which is, obviously it's essential for that to happen, and DBT does provide a structured way for that to happen. The second, and I'm not going to go through all the details on these, but another common one, a little bit less common in the US, but minimalization-based treatment. This has the longest research study done. It shows gains in symptom reduction over 8 years out. It's an approach, and it's the idea that I've kind of referenced already, that people can lose their ability to be aware of what's happening in their mental life at points. So we've all had the experience when our distress goes up of not having real sophisticated, reasoned analyses of what's happening and concluding that someone in traffic that day woke up with the idea of making our lives miserable. They probably did not wake up trying to make our lives miserable, but we are applying this idea to the situation because that's how it feels to us inside, and we've stopped thinking. Does that make sense? And reactivating people's thinking in the face of that distress is the goal. So that's what minimalization-based treatment teaches, harps on, works on. How do you keep thinking about your own experience, about the experience of others in accurate ways, even as your distress increases? And the third that I'm going to talk about, general psychiatric management. It turns out that in a head-to-head study, this was found to be as effective as DBT, and it basically takes the APA treatment guidelines for BPD, and the treatment was really developed after John Gunderson's work, including the 2008 revision of his clinical guide. And they use clinicians who have an interest and experience in treating BPD, and turns out patients can do pretty well. And I'm going to try to highlight some of the commonalities. I'm going to skip the rest of this, but I'm going to highlight the common features on this slide. Of all 6 of these treatments, they're all designed to address borderline. They get at that core problem that I was trying to describe of not being able to think straight in the setting of emotions and trying to make sense of your own experience better. They're structured. They have groups and individual work. Importantly, they're coherent and they're stable, not reactive. And as you can imagine, working with borderline patients, there's a lot of reactivity around, and mental health professionals are certainly guilty of getting reactive in the setting of it. But if you've got an idea of here's how it works, here's what the treatment is, here's what we do, it tends to go a lot better. Contracting, making agreements of what we're trying to treat, what we're trying to do. Having a crisis plan. What are we going to do if it goes wrong? And how do we anticipate that so that it becomes an exercise in predicting behavior and working in it? Using supervision, and professionals working with this population need supervision. Families working with this population need supervision. Patients themselves need supervision. It's hard. It's hard to be in the setting of people's emotions that are aroused, especially in relationships that are important to them, including the relationship with a family, including the relationship with a therapist. And it needs sorting out to make sure that the therapist stays on track. Therapists are generally active. These patients do much worse when therapists just sort of sit back and listen to whatever comes and don't help them sort it out. And they monitor progress. Is this getting better? So general psychiatric management includes treatment reviews, at 4 weeks, at 3 months, at 6 months. Is this working? And if it's not, let's do it differently. And I think that that's an important aspect of this, that we're working toward a goal. This isn't therapy for the sake of being in therapy. Now, I have the world expert psychopharmacologist sitting here, and I'm going to try to talk about meds. Great. But I'll give you a couple of thoughts. First is a dilemma that Joel Paris described in his book, that we can prescribe antipsychotics, but this isn't true psychosis. We can prescribe antidepressant, but patients with borderline don't have classic depression, as I was talking about earlier. We can prescribe mood stabilizers, but the affective instability of BPD is not the same as the symptoms of bipolar disorder. So we're left with trying to figure out a schema that makes sense, and this is not an easy task. In general, psychotherapy is an adjunctive, psychopharmacology is an adjunctive role for therapy. Can help with affective instability, impulsivity, and some of the psychotic-like symptoms. And the studies are that patients who are on meds, with the exceptions of benzodiazepines, generally do better than patients who aren't. So it's a reasonable thing, although it has its pitfalls, and I'm sure we're going to hear a lot about that this morning. But formulating requires that we understand BPD as an engine that fuels the mood symptoms, the substance abuse, the anxiety disorder, the eating disorder, the impulsivity. And reactive treatment can be tough. And I now work at a major medical center which is designed to be reactive, which is what the rest of the healthcare system actually is. And it's probably a good thing, because if you go to the ER with chest pain, you want people to be reactive. It's important. They will save your life. However, if you go to the ER with emotional distress, complaining of vague pain, and you get that same level of reactivity, you could really end up in the weeds. And people with borderline who intersect with the medical system often do end up in the weeds, because the medical system has all of this reactivity built into it, and it doesn't work so well. And I think that we've got a long way to go to, we're just trying to get psychiatrists, psychologists, social workers to understand borderline, but trying to get internists and emergency room docs to understand how to work effectively with this population is going to be a challenge for probably the rest of my career. For medical symptoms and BPD, turns out people with BPD have more chronic medical conditions. They're less likely to see a primary care doc. They're more likely to use an emergency room. This probably doesn't surprise any of us. And they did a great study of migraine headaches, and I just like this study, where migraine headaches are migraine headaches. They're not that easy to treat, but you just sort of follow the algorithm of you try this med first, you try this med second, you try this to prevent, you try this to manage in the acute setting. And you got to follow the rules if it's going to work well. And even then, it doesn't always work well, but you got to be able to do it. So they enrolled 50 borderline patients and 50 non-borderline patients, and they tried to get them to follow their standard algorithm. Turns out that the borderline patients had more medication overuse headaches, so they were overusing the medication, causing a rebound migraine headache. They had more unscheduled acute office visits, and they had lower overall treatment response. And I think that kind of makes the point that I was making earlier about the reactivity in the system. It just doesn't go so well, and providing structure, stability is really important for people that have intense emotions. All right, so here are the pearls, and then I'll leave the rest to Dr. Silk. Collaborate, set goals, be methodical, consider borderline the primary diagnosis. And here's the last difficult one, because Perry's in the front row. But I want to talk about families a bit. And this is, I think it complements the Family Connections program. These are the guidelines that we use at McLean. And to start, I think it's important to acknowledge that families with borderline in the family struggle with their own reactions and responses that are actually pretty similar to professionals that are working with the patient population. And helping families decrease their own reactivity is key. And in my experience, the best way to do it is to just decrease the blame, rather than getting blaming in the face of somebody's distress, which is easy to do. It's easy on my end too. It just goes a lot better to stick with a level of describing, okay, this is what it is today, and what can I do to be effective? Family involvement requires some structuring, and I think having support groups, education groups, collaboration with other families in the same boat is important and necessary. The principles of family work are a little bit different than for other psychiatric patients, and I'm going to go through some of the principles because they focus on the specific part of BPD. But validation and a focus on effectiveness can make for a real change in families. I'm preaching to the choir for the most part on this one, but we'll see if there's any nuggets in here. 5 guidelines. The first is to go slowly. This is not something that changes overnight. In fact, it changes over years. And changing the family system doesn't change overnight. The family system changes over years as well. So go easy on yourselves. This is hard. No one signed up for this or said, oh, please, let's all. In fact, the patients with BPD didn't sign up for this either. It's frankly no picnic for anybody. So, okay, it is where we are. I think where families can get off track, in fact, where professionals, the residents I work with do this all the time. They give all this positive, you're doing great kind of thing. Well, fine, but as I just told you about staying dialectical, that leaves the person with BPD to say, no, I'm not, and things just don't go so well. So being able to acknowledge this is hard, and there's a experienced hospital staff, the nurses on discharge, they don't say to borderline patients, I think you're going to do great. They say, this is going to be hard going out there. And it makes it a lot easier to say, okay, it is going to be hard, and then we can talk about it. So avoid the you can do it reassurance. Second is to work in small steps. That's realistic goals that are attainable. I worked with families that they were just insistent that their daughter have a job, which would have been good for her. But it wasn't going to happen that day. And so the more the family fought for the job, the more frustration everybody got. And so, okay, what is doable today? Not saying job's not important. Job is important. But how are you going to get there effectively? If it works to say, you have to have a job tomorrow, then it would have already worked. So we're looking at how do you break this into small steps and stay effective. Second, staying engaged, and I think Perry will show you some data on this later, that families who are emotionally engaged, in general, that's a good thing. We don't want families to just be neutral, and same way we don't want therapists to just be neutral and dull. You have to be exciting and interested. At any rate, engage but modulate it. Appreciation is normal. Tone it down a little bit. Disagreement is normal. Tone it down a little bit. But basically, the part that's really important to tone down is the blame and judgment. That just escalates anger, shame, fear, reactivity. Toning that way down and sticking with describing what is happening rather than assessing what is happening is a great way to go. That's, by the way, very difficult because parents' job is to learn how to assess what's going on so they can see the problem. I mean, that's what you do with a child. It's very easy to get in that, especially when someone's not doing well. So this is a very challenging thing to learn. Frankly, it was challenging for me becoming a psychiatrist, learning how to decrease my own judgment in the face of people's distress. But if you can learn how to do it, it really can go very far for you. Maintain family routines, find time to talk about neutral topics. Increasing the conversations about things that are neutral can be helpful. Marshall Linehan said this just beautifully, that assuming the worst in people is destructive. And I think that really summarizes it, that if you catch yourself assuming the worst, sort of like that person who cut me off in traffic and I was assuming that maybe they were trying to torture me, it just doesn't go very well. And if you start assuming that your kids are actually trying to torture you, it's probably not going to go so well. So, makes sense. You've all done that, right? I mean, I am, yes, okay. No, never, no, not you, sorry. Everybody else has done. Okay. Managing anger. Now, this is a complicated one, and because anger is a part of BPD, and I don't like being yelled at, and most of us don't. So it really creates a dilemma, because on the one hand, people are doing what we're asking. They're putting their feelings into words, and they're saying, I'm angry. This is good. And it's hard to remember that because no one likes being yelled at. So if there's a way to, if somebody's putting their anger into words rather than behavior, remind yourself that's a good thing. But if there's a way to acknowledge the legitimacy of some part of that, it can go a very long way. to acknowledge, okay, I see your point. It really can go a very long way because it helps somebody say, wait, maybe my internal experience does make some sense and maybe I can sort it out instead of disconfirming the internal experience. You have no right to be angry with me about that. Well, that may be true, but it doesn't go very far toward being helpful. So if there's some way to acknowledge, we'd never encourage anybody to acknowledge something that wasn't true, but acknowledging, okay, I see I pissed you off. That's just true. You can see that. So at least acknowledging the legitimacy of the experience can go far. So rather than rejecting the accusations, and please resist the temptation to over-personalize it. That's a useful thing in psychiatric training, the concept that some affect that comes our way is actually just addressed to occupant. It's not specifically, right? You're just there, and you don't need to make it all about you. It may be, but okay. The next one, addressing problems. Self-destructive acts do require attention. Please don't ignore them. When you're collaborating to solve a family member's problem, collaborate. Ask them what they can do. Ask what you can do to support and help. I think a lot of people start to feel responsible for the decisions of somebody who's making fairly poor decisions, and that causes all kinds of problems. So remembering, okay, it's their life. They do need to make the decision. Your job is to be helpful. Ask what you can do to help. It's helpful for parents to stay consistent with their strategies. It's hard, but if you're able to sort of just hear the rules, just do the rules. I used to give parents that I would work with the brochure version of this and ask them to put it under their pillow and read it every day and just keep following the rules. Because eventually you start following the rules and then you're like, oh, then the next explosion happens and you go back to your other way. It gets very inconsistent, so helpful to stay consistent. If you have concerns about treatment, it's important to let the family member and their treaters know. And then on limit setting, again, you're going to hear this afternoon Randy Kreger's talk, but setting limits by stating the limits of your tolerance. If they're clear and simple, they work better. If you're using limits as coercion, it just doesn't work so well, and it's not actually a limit to begin with. So if you say, if you come home at 2 o'clock in the morning drunk, you can't live here, that could be your limit. If that is your limit, you need to abide it. Not that we necessarily encourage that. But if you say that, it needs to be your limit. Otherwise, you're into coercion and things just escalate. This is a very difficult thing, and most of you have been through it. I'm getting lots of nods. And at the same time, no need to tolerate abuse, threats, hitting, spitting. Walk away and discuss the issue later. So anger put into words, we want to try to work with. Legitimize what part. If it's abuse, it just needs a pause and just matter-of-fact tone. Like, okay, we'll come back later. This isn't going to be a good time to discuss this. And then do come back later. Okay. Professionals, please encourage parents to be involved. This is missing in most places. The patients end up in treatment, but there's nothing that connects the family with this. And it's important to learn about BPD. I'm glad to see everybody, all the consumers and family members here. It's great. Please join and be active in NEA.BPD and NAMI. There's great advocacy organizations, and there's certainly a need for advocacy. I helped write this analysis of parity in Massachusetts so that borderline could be considered a parity diagnosis under the state mental health parity laws, which doesn't seem to be moving very quickly, but at least the Department of Mental Health has certainly supported that. There's so many opportunities for local advocacy being involved. All this frustration needs to be put somewhere useful, so put it into advocacy. And family connections, I'll let Perry tell you about later. Do I have time for questions, or do I?